there's anything top secret proprietary that should be earth-shattering, but why don't you go ahead?
So this was basically, this is, like Dr. Kanter said, one of the systematic approaches that we do at Kaiser. It's a team assigned to do these hypertension guidelines nationally. And so when you look at Dr. Kanter's placed leads in every single disease state. So we have Southern Cal leads, since we have over 9 regions. Each lead in each area gets together and they come up with a national guideline, and they review all the evidence-based medicine journal review articles. And this was published and given released in August of 2014, because it took a little bit while after 2013 when the JNC8 was released. They wanted to make sure, and Kaiser wanted to vet if they agreed with all the recommendations and make sure they aligned, and everybody has to agree on a national guideline. So this is our JNC8 guideline. JNC8 did not change the standard definition of hypertension, so JNC7 we still went with what was defined as a diagnosis. So it's the same, it did not change. A lot of our guidelines too, first looks at, it excludes some of our other populations. So if there's different populations like CKD, non-pregnant, CHF, those will be looked at differently, and there may be, the nephrologist will put together those guidelines based off of those populations. So this is just for basically primary care and excludes some of that, those different populations. So the first line therapy in general followed exactly the JNC8, so I don't want to go through all this because you guys have heard all of the JNC8 recommendations, but we do have a differentiation between the non-black population and the black population and the CKD population. Here is our algorithm, so it's very straightforward. We try to keep it pretty simple, and these algorithms then are passed on to all of the clinics and through our functions. So the pharmacists that works in these clinics, the nurses, the MAs, all of them get these guidelines, and then they can put them in place into protocols so that depending on your scope of practice, what you can start, whether you can start medications, titrate medications, order labs. So all of this information is shared. But you can see here, you know, we picked a combination because Dr. Handler, which you heard before, and the JNC8 really believes in 2 medications at once because most of the patients will need 2 medications. So we do align with that in our formulary. It's just what our formulary chooses as our first line agent. Then, as you can see here, you go to, if an ACE inhibitor intolerant or pregnant potential, then you'll go to a thiazide. If not, you'll go to a calcium channel blocker or spironolactone. And then all the bottom considerations are down here. If you have any other interfering agents, it does talk about the white coat effect to check twice. We do have that systematically in place where they do measure in each clinic if it was only taken once versus twice. And so we do really push for 2 vital signs, and within 15 minutes, I think, is apart from each other. So, and all of these things that have been put in place are measured constantly through physician reports, through MA level reports. So it is really, the organization's held accountable through our systems to follow these guidelines. And I think that's an important piece. You can put together as many protocols and algorithms and all these things in place, but if you don't have the system that Dr. Kanter had and the culture that's been put in place at Kaiser, this just doesn't work, you know. And so I think the accountabilities, and one of the things that Dr. Kanter did with the specialty clinics, he created a s'mores report, a specialty report, which, you know, I think that's when he started getting, you know, when I saw a lot of difference in our specialty clinics, was those reports were given out, you know, every few months, showing each time they went into an office and this was not done. And you could drill down to the MA that didn't do it. I mean, that's how powerful these reports were. And so as a DA, you could have those conversations. Well, you know, you are the only MA out of the 10 I have in this clinic that's not doing the second vital sign report, and we need that.
Is there a big difference in cost in Kaiser between generic ACE and generic?
No. I think it's...
Is there any evidence of ACE then is better than the R? Because you do end up having a lot of people side effects with that brings back.
We do have a contract with lisinopril over losartan, but losartan was added. But before losartan, when we had the combination of Hyzar, it was really costly, and it still hasn't gone down as much as the Prenzide. So as if we do get a competition of the ARB combination, we would look at that, but it is pennies difference, but those pennies with big population like that pharmacy ends up really pushing for that to be your preferred agent. So we do have Hyzar now as part of our, and is an option if they do have a cough. We do convert patients to Hyzar generic. So all of these are generic medications that are available and follow the JNC 8. Again, our definitions may slightly differ a little bit about how we define CKD based off of our nephrologist recommendations and our age requirements. Also, but nothing differs with the pregnancy in women, but it just goes into explaining why we want to avoid these. And we do have alerts built in our system that shows if a patient's pregnant and on one of these medications, the physician will be notified. Here's our kind of medication management. So the expectation that's set is once you find a diagnosis, then you need to up titrate within a few weeks. And so what happened was most of these patients were then managed through a care management system or panel management system where they would come in and see that MA for a repeat blood pressure in a few weeks. And then if they had a high blood pressure, they could be sent down to the nursing clinic typically, or if the nursing clinic was on that floor, nursing clinic has some protocols in place where they could at that time titrate up. So it's a very systematic approach, and you have all these handoffs, and it works really well, and the expectations and protocols are there. And so that's how we up titrate and get these patients in control, and I think that's what's been so successful because they don't have a co-payment. There's also telecare and telephone appointments if the coming into clinic is too difficult for patients. We also have programs in place that you talked about, Mary, where we have over 13. I brought 13 different clinical decision supports in place, and these fire not only if you're a pharmacist, if you're a nurse, an MA, inpatient or outpatient or a specialty. So there's 13 different alerts, and the alerts tell you if a patient's uncontrolled, if they are maybe too well controlled. So they're safety for treatment and for too much over-treatment in our. So there's 13 different alerts. I didn't bring the data that we have to show how often these alerts fire and how often they're followed. We're getting better at getting that information, but we do have a system in place where alerts are being ignored too much. They do come up for review to be turned off. So we do have systems in place for this type of intervention, which does help along with all these other systems we have in place. And this was your last slide, so you want to...
I just... thanks, Jennifer. I just want to emphasize sort of the leadership aspect and the systems aspect, that merely handing out a titration algorithm will actually move the dial sizably, but not get you where I think we all need to be in meeting the million hearts target and the other targets that we've talked about in this room of 90th percentile. And yeah, just as an anecdote, our specialty blood pressure medicine, blood pressure measuring program probably wouldn't have gotten started had we not started with specialists doing mammograms. So it's all interconnected in one big delivery system. Whether one starts with one disease or not, it sort of depends where you're at in your journey, but I still think the main key is culture, leadership, and systems will move quality, whatever area you're at. So I wanted to thank Hattie for inviting me and the Right Care Initiative. I think this is an exciting program.